Welcome to The Anxious Voyage. If you think that title sounds bleak or foreboding, one of two things must be true. You're very lucky, or you need to get out more. On this program, we share stories of life and living. We compare notes. We discover commonalities. We accept that life is a glorious, heartbreaking thing, and we embrace and celebrate all of it. Take the ride with us. We're glad you're here. Now, here's your host, Mark O'Brien.
Hello and welcome. We're glad you're here with us today. We are coming to you again and as always from World Headquarters in Middletown, Connecticut. This weekend in Middletown at beautiful Lake Bezic, we will be having the annual Human Cannonball launching competition. The competitors will be judged on the length of their flights and also their acrobatics while in flight. We try to do this before the lake freezes because otherwise it gets a little tough on the contestants when they land. They won't be able to wear life jackets because it causes friction when they're in the barrels of the cannons. But for those participants who aren't able to swim, the Middletown Parks and Rec Department is going to offer 10 minutes worth of dog paddle lessons before the competition starts. So it should be exciting as always. I'm really happy to introduce my guest today. We met a year ago, June, at a gathering by some organization called Well for Tech. Cathy was one of the participants and presenters at that, and she and I had a chance to talk there. She and another woman who founded a company called Empowered Together, named Sarah Spear, who's been a guest on this program, are both to blame for the fact that I even do this program. So you could take that out on her later if you want. Anyway, Cathy, I'm glad you're here, and you can turn your camera on right now if you would like.
Okay, hi.
Hi, there you go. Welcome. I am indeed glad you're here. I do want to say that Cathy is co-founder of Parallel Testing and launched Parallel Profile. Here's the part where my mind starts to get blown. To reduce the number of deaths, 128,000 per year, and inpatient admissions, 2.7 million a year, from adverse reactions to FDA-approved medications. According to a senior exec at GlaxoSmithKline, 90% of drugs don't work for 30 to 50% of the people who take them. My first comment is wow. And then I'll follow with the question, wide open, what in the hell is going on? How can this even be?
Yeah, it was surprising to me as well. I came to be involved in the pharmacogenetic area because my husband, my mother, and two of my friends all had adverse drug reactions within 2 years. Two of them died. My mom and my husband survived, primarily because of who happened to be there at the time. My husband was rushed to the ICU, and I get a call. I happened to be in town. At the time, I was traveling a lot on business. And I got there and they told me to go home and get my kids to bring them back to say goodbye to their dad because they did not expect him to make it. So because of my background working at a 7 hospital health system in the CEO suite, I knew about never events, things that should never happen. And so I asked for the chart. And it was one of those hospitals, so they knew me, and they handed it to me, and I looked at it, and I said, it's this. Take them off this drug and do this. And the nurse said, well, I can't do that. Only the doctor can do that, and he's gone, and we have to get him, and all this kind of stuff. So I was able, because I knew the CEO of the hospital, I was able to get someone to come down and bring down a against doctor's orders document for me to sign so that they could do what needed to be done and saved his life. My mother had a brain hemorrhage. And it just so happens when they brought her into the ER that the top neurosurgeon in Minnesota was there. He was just leaving. He'd done surgery that day, and he turned around and went back and saved my mom's life. So those two were lucky. My two friends were not. One was from her chemo, shredded her heart. And the other one was acute leukemia from his eye drops.
Oh,
Yeah.
how?
And so I Googled, I go, how many people die every year from adverse drug reactions? And it popped up and I went, what? And I did a deep dive to find out how it could stop happening so much and discovered pharmacogenetics, which has been around and, available since before 2009.
How is it, especially in the case, and I'm assuming that your husband's situation was before your mom's, or were they at the same
Yes.
time?
That my husband's was first and my mom's was second.
How at the point at which your husband was facing his challenge, did you even know or how were you able to recognize that he might have been having an adverse reaction to something, especially when apparently the folks at the hospital did not?
Yeah, I think it was because of I had a unique experience in my working in that office. We would prepare the decks for the board meetings every month, and we had 7 meetings every month. And one of the things that was in the decks was the report of never events because it's a liability. And so I would review all the decks that were done to make sure that they were appropriately done before they were sent out to be presented at the board meeting. And so I reviewed the never events every month 7 times, and there were dozens every month. And so I've long told everyone that I love, never go to the hospital alone. Make sure there's always somebody there with you. And many of them were adverse drug events. And then when I was leading the healthcare strategy practice at Towers Watson, I would review what's called outlier claims. Every quarter, any employers who self-insured, they always look at the claims which were above their limit. Everyone has their self-insured up to a limit, and then they have reinsurance. And so we would review the outlier claims, and I would see adverse events from drugs on a regular basis, maybe 20 to 25%. Some cases a third were high cost claims. My mother's event was $1 million because she was in a coma for months and then to a rehab facility, and it was 6 months before she was home. So I just had been aware enough to recognize it when it was happening.
So was it, I'm sorry, did you say Towers Watson that you were working for?
Uh-huh.
Okay. So this goes back a while, but at one point in my working life, I spent 8 years working for the division at Travelers that sold health insurance.
Oh.
And, at the time they were establishing PPOs and HMOs. So obviously they were trying to recruit providers into these networks.
Mm-hmm.
Travelers also processed claims. And if they weren't processing claims for fully insured groups, they were certainly working with TPAs that were processing the claims for self-insured groups. So as I'm about to ask this question, I already feel naive. How is it that the insurance companies, the TPAs, and the providers are not talking to each other to recognize these outlier claims and to start connecting the dots that you did? I really don't believe that should boggle my mind, because I know how bureaucratically dysfunctional those places are. But how is that possible?
Yeah. It's like so many things, it falls into the category of not my job.
Oh,
People
wow.
are really focused on the part that they do, and healthcare is very siloed. I mean, just the fact that all of these doctors, and I know this from working in the hospitals, but I also know them by working with the Centers of Excellence on PGX around the country as part of the American Society of Pharmacovigilance. Um, what happens is doctors know about the drugs in their specialty, right? And
Yeah.
when you go to the doctor and the doctor, the nurse or someone during intake says, what drugs are you on? You list them, right? And I've had doctors tell me very candidly that they don't even know what those drugs do or what they're for, right? It's standard protocol to ask, but they know most of them know quite a bit about the drugs they use every day. But I will tell you that the doctor who he was a cardiac surgeon, and he was number one in the state. That's why I took him where I did. We were not even living in California at the time. Okay, but we went to California for it. And he prescribed him a drug that didn't have a black box warning on it yet, but 3 months later it did.
Oh.
And he said to me, in my 12 years of prescribing this drug, I've never seen an adverse reaction to it before. And it's not this drug. It's not this drug. That's not what's wrong. And I told him, I said, look, you're not seeing it this time. Maybe you didn't see it the last time it happened either.
Yeah.
So if you're not taught how to recognize it, if you're not taught to expect it. Now, I will tell you that a very small percentage of people who use my friend's eye drops get acute leukemia, but it's a side effect listed on the box that the eye drops came in. Side effects include acute leukemia. Did his doctor recognize it? No. I got a call. We were in Costa Rica on vacation, and I got a call from my friend's partner, and he said, Cathy, we try not to call you, but Mark's in the hospital and nobody can figure out what's wrong with them. Could you please come home? So we did. He lives a couple hours from me. So we flew into Miami, and I got to the hospital. It took me, I'm going to say 10 minutes.
So the next thing that comes in.
The doctor in the hospital doesn't know anything about ophthalmology drugs, right? Yeah.
So it was that ophthalmology drug was a prescription.
Yes. Oh,
Okay.
absolutely. For macular degeneration.
Okay. So, I was thinking about the fact that you said not my job. And obviously enough, I can understand that. And it also seems to me, and by the way, in my insurance life, one of the things that I had to do was write sales incentive compensation plans. So people do what they're motivated to do.
Mm-hmm. Right.
So
absolutely.
I know it's really popular to beat up on the pharmaceutical industry, but if you're a pharmaceutical sales rep and your job is to be selling drugs to people who can prescribe them, that seems to me it's yet another way in which potential consequences or side effects could just get lost. Not my job, and it is my job to sell this stuff.
Mm-hmm. Yeah,
and
I'm not suggesting there's any bad guys anyway up and down the chain, but I will suggest that there's things that need to be changed because, for example, the PBM, Pharmacy Benefit Management, decides which drugs are going to have the low copay and the higher copay. So atorvastatin, for example, is a statin. And maybe that's one, I'm just looking at my notes. I want to make sure that I get this right. Yeah, it's atorvastatin, maybe a higher copay. Maybe your company's lower copay is a Crestor generic. Unfortunately, atorvastatin is much safer after you've had a stroke than the other one. But so this patient's had a stroke, right? And they've been on Crestor for years and have been fine. And they renew the prescription. But atorvastatin is far superior for someone who's had a stroke. Okay?
And
do you know that? I mean, my husband's doctor did not know. He was concerned about my husband losing weight. And he didn't know until I told him that metformin, for some people, causes weight loss. And they were looking into all sorts of things to figure out why he was losing weight. And I'm like, well, let's switch him off metformin for, a month and see what happens. Well, that was it.
So I recognize when you said Crestor, I recognize that as a brand name.
Mm-hmm.
So
but there's generic versions.
Oh, okay. And that's what I was going to ask. So are we saying that different generic versions of what I would have imagined would be the same formulations have different effects or different levels of effectiveness?
Well, I think that the definition of the word generic is kind of like the definition of the word allergy. Allergy, people say, oh, well, then he's allergic to amiodarone. And I go, well, no, because an allergy is something, but, so it's generic or similar alternative kind of thing. So for example, I take Synthroid. Levothyroxine does not work for me. It's an alternative that is designed to work, but it's not exactly the same.
Okay.
So one works for me and one doesn't. Okay, that's another kind of difference. Sometimes they have a binding agent or some other, is it clinically actionable the same? Yes. But
wow. Okay. That's very good to know. And I'm just going to throw this in here. I hope my wife is listening. I don't know if she is. But she also takes thyroid medication. So I hope she heard what you just said about Synthroid. I think it's a little too much to hope for that her doctor might be listening. So I'll just.
And I have to pay a lot extra for the Synthroid.
Yeah. Well.
So that's another thing that Parallel Profile is recommending to employers is to have what we know as what's called in the industry as an auto edit. So when I have a Parallel Profile genetic test and it says that this drug will work for me and this drug won't, that they automatically change my copay. So I'm financially incented to do what'll work. Because my husband's diabetes medication didn't work years ago until we did the genetic test and we switched them, and his A1C worked for the first time in 20 years. So you don't want him to take something that doesn't work.
When someone reaches the age to qualify for Medicare, mm-hmm. and then gets an Advantage plan, does that introduce another level of complication? Mm-hmm. if Advantage plans will cover some medications and not others?
Mm-hmm. Yeah.
Wow.
And the state of California is the only one that's done this so far, but we're really campaigning for more states to pass this since the feds are slow. So in California, if you're on Medicaid or Medicare, the PGX test has to be covered.
Okay.
But elsewhere it does not. And the thing that's interesting is that Medicaid has to cover it, but individual insurers don't. Okay. What can I say?
Okay, maybe you can't answer this question, but how does that work?
I don't know. I don't know. We're just glad to see it's a step in the right direction.
Yeah. Well, all I can say is that none of this renews my faith in bureaucracy. That's for sure.
Yeah.
Yeah.
We're
I won't even get into this, but when I think it's not my job, my next thought is psychology. Well, okay. Well, what do you care about? If you're willing to say it's not my job, and you have a job that could influence the health of people, what I mean, what's your psychological profile?
Yeah, I think part of it is that they don't know what they don't know.
Yeah, true.
I mean, from an individual standpoint, I know because of a very unusual set of job experiences that I had that the vast majority of people don't to
Yeah.
have those combination of things. I also have an extremely large family. I have 74 first cousins.
Whoa. Woo.
Okay. And when I was a child, I remember the first time genetics was discussed in my presence. I was 4 years old on the beach in Acapulco, and my aunts were talking about it, right? A lot of people didn't really discover the world of genetics until 23andMe started,
Yeah.
you
Well, that's a
know?
good point.
But it's been a conversation at our family dining room table my whole life. My grandfather was a scientist, grandmother was, this was a conversation. A lot of doctors in the family, a lot of nurses. And so I believe that I see things that a lot of people don't have that opportunity. But I also see my genetic pool right in front of me. We look at, oh, this cousin and this cousin have a lot in common, and these cousins have nothing in common. It's really the variety is really great, great. So the thing where the doctor says, well, are your mom and dad still alive? What did they die of? I can tell you it's so not relevant that my grandmother had breast cancer, because not a single person out of the 60 women related to her have had it.
Interesting.
Including her descendants and their descendants. So, it's really interesting what genes you get and what genes you don't. We genetically tested everybody in the family after what happened to my mom. And there are other people in the family who cannot take that drug. But most people can. But there's probably a dozen who can. And it was really good to know that. So we didn't, go through that again. I am multiracial. I look like my French and Swedish mother, but a lot of my innards come from my Mexican dad and my Native American grandmother on that side. And so I respond differently to medications than my sister does and my brother does, but the same as I do to my other brother, my other sister. So, it's you can't tell by looking at you.
We're actually in the next segment, we're going to get into the whole issue of genetics and ethnicity. I just want to comment before we go to break that whether they know it or not, there are a lot of people who should be very grateful that you had the upbringing you did and that you were exposed to all that stuff. So hats off to you for your work. We are going to take our first commercial break now. So Cathy, I'll see you in 3 minutes, and everybody else, keep it where it is. See you shortly.
Everybody has a story. Everyone's story deserves to be told, and the only bad stories are the ones we don't share. That's why Mark O'Brien created The Anxious Voyage. It's Mark's conviction that every story deserves to be shared, and his purpose is to give people in all walks of life from any circumstances a chance to tell their stories. The Anxious Voyage is now on syndicated Dream Vision 7 radio network every Monday at 1 a.m. and 1 p.m. Eastern Time, with live broadcast every first and third Monday at 1 p.m. Eastern. Please tune in, please join Mark, and please share your stories.
Ever wonder what it's like to have your own radio show? Well, wonder no longer, because you can dip into the radio airwaves by being host for the day on syndicated Dream Vision 7 radio network. It's a fabulous way to get your radio feet wet. It's an opportunity to market your business, modality, or book. Have a guest, mention a sponsor, and take callers. Or you may want to facilitate a lesson by going solo. It's up to you. Listeners can be online, mobile, in cars with Bluetooth, or listen through Amazon's Echo by asking, Alexa, play Dream Vision 7 Radio Network. For more details, go to dreamvision7radio.com and click on Host for the Day.
You can't establish your brand's authority without a voice. That's why, since 2004, O'Brien Communications Group, OCG, has been helping companies establish their authority, find their brands, distinct voices, and position their brands effectively and persuasively. So effectively that 9 of OCG's clients have been acquired by other companies. OCG's business model emphasizes efficiency and results, not hourly billing, markups, and media commissions. That ensures OCG's advice is unbiased and its clients aren't at financial risk. If you're ready to find your voice and use it to tell your story, OCG is ready to help. You can find O'Brien Communications Group on the web at o'briencg.com. That's OBRIENCG.com, or call 860-944-9022.
Calling all authors. Have you been considering an audiobook? Well, look no further. Come take advantage of Dream Vision 7 Radio Network's unique in-house audiobook production, which includes benefits and bonuses from our radio station. Let our knowledgeable staff guide you to create the audiobook you've always dreamed of without breaking the bank. Check out our full one-stop service from A to Z, including the ACX process. Schedule a free consultation by calling 508-226-1723. That's 508-226-1723. Or go to dreamvision7radio.com.
This is Dream Vision 7 Radio Network, uniting mankind with universal love. Our shows are created from the heart, bringing each listener to a place of divine enlightenment. Breathe, relax, and enjoy. Let life flow.
Welcome back, everyone. Cathy, thank you for coming back. I want to let everybody know, thanks to you, because you shared it on LinkedIn. You posted last Friday that the FDA has published their new guidelines to improve inclusion of diverse populations in clinical trials. And I just want to cite a little bit of your response to the FDA. African Blacks respond differently to medications than Caribbean Blacks. American Blacks respond differently from either one of them. People who are 50% Black and 50% European Caucasian look like African Blacks. You can't tell how their racial reality will impact a drug effectiveness or safety by looking or by what they identify as. And please, let's not, pretend the designation Asian is useful in this very diverse category. And before I ask you to say more about that, I just want to share. My older son is married to a Black woman. So my first thought is, of their children, they have 2. My second recollection is that my daughter-in-law is named Lauren. In Lauren's first pregnancy, they were in Connecticut. In Lauren's second pregnancy, they were in North Carolina. And neither of the doctors who worked with her on her delivery had any idea of what the implications of sickle cell might be. And so it was nightmarish on both occasions.
Oh my God.
So, and the kids are fine. She's fine, thank God. But I'll just throw that in as background. So, I'm absolutely fascinated, and overwhelmed, I think I would say, at the number of variables that there might be to compute in looking when trying to treat somebody or prescribe, in looking at their ethnic or genetic profiles and their chemistry. How do you do that?
One of the reasons why, again, you look at the things that went on in your life that made you think of something. I did a multi-year project for the Secretary of Health in the Bahamas. And we were looking at building a center of excellence hospital, designing a hospital of the future in the Bahamas. And one of the things we're looking at is the protocols. And I learned a lot about Bahamian residents who are Black versus white, and what the significantly higher cancer rate was for Black Bahamians compared to Blacks in the US. And it was just because when they're looking at this, you always compare different locations for hospital effectiveness, for healthcare quality and all that kind of stuff. And we were basing everything on the centers of excellence in the US and what those centers did, Johns Hopkins and Mayo and Cleveland Clinic and MD Anderson, et cetera. So we were looking at those and profiling it. And then it just occurred to us during that project to say, is this population similar to those populations? Are outcomes different in Atlanta than they are in Salt Lake City, right? And so we just kind of dug deep into it. And it was really interesting, the differences in the rate of certain diseases, comparative. So that was just in my mind when I started seeing all this racial health equity stuff going on. And I'm like you got to ask them where they're from. One of our medical advisors, her father's from Ghana, Africa, and her mother's Canadian. Right? And she lives in Atlanta. And everyone who treats her is going to assume that she's an Afro-American Black from Georgia. And she's not.
Wow.
Right. And the other thing that's unique, again, because of my large family, there's only one race of human beings on the earth right now that I don't have a relative who's that race. Okay. So I look around. I mean, it's really funny because pictures on my refrigerator, people go, oh, who are these people? And I go, oh, those are my nieces and nephews. And they're going, what? So it's just, my grandfather used to joke that our family motto is we sleep around. We really like to mix it up.
When you were talking about having worked in the Bahamas, and you were talking about different incidences of cancer, the first thing that went through my mind was environment. So, you can see all kind of documentaries on Netflix or, even theatrical releases about, people who live in areas where cancerous chemicals were put in their water and all that stuff. Did you find any of that to be a factor in the Bahamas or elsewhere?
Not that we found.
Wow.
Not that we found. Because it was interesting too, because we looked at the higher rates in some parts of the US. And it was really interesting. There was a cluster of breast cancer around the Bahamian embassy. And the Bahamians who lived in the US, not in the Bahamas. And, a lot of people, I have a friend here in Florida whose parents are Bahamian, but he was born here, right? So but you don't know if a prior generation was exposed to something that affects your genetics 2 generations later. Right?
Yeah, it's the only thing I can think to wonder is given all of this and all of this apparent, at least to me, complexity. If you have to be admitted to a hospital, or if your doctor diagnoses something and tells you, it needs to be treated, especially, I guess, pharmacologically, I don't know whether I should ask what kind of testing should you have, or how much testing should you have?
Right. Well, for example, I have 2 relatives right now, very close to me, with different kinds of cancers, 2 cancers. Both of them are the spouse of one of us. So they're not in my gene pool.
Mm-hmm.
But, both of their spouses called me and said, okay, where should you go? What should we do? Get a second opinion, all that kind of stuff. And I directed them to 2 places that do pharmacogenetic testing before discussing a treatment plan. It's the first thing they do. Okay, Mayo and City of Hope, right? There's a dozen centers of excellence around the country that do it, but it's not required everywhere. And so where you go is significantly more important. There was a study done on second opinions, and when you do a second opinion at a center of excellence, your diagnosis and treatment plan is changed over 40% of the time.
Wow.
Okay. So and in one case, they did something completely different and better diagnosed the type of cancer. And in the other place, they said, this type, you shouldn't do anything at all. It's so slow growing, and at your age, it'll never overtake you in time. Right. And so instead of suffering through horrible chemo and surgery and all that, and that was a type of non-Hodgkin's lymphoma, but the local hospital near their house had them all set up to go through a protocol. So it's really, where you go is really, really important. And you mentioned Medicare Advantage earlier. And that is my number one problem with Medicare Advantage, is it limits where you can go. And I've encouraged people, one of my son's little league buddies' grandfather had cancer. And so my son came out of the dugout of the game and came over and said, you got to help this grandpa. So what I did is I bought him a plane ticket to MD Anderson in Houston. He got reworked up. He got second opinion, got a treatment protocol. And then I met with his personal physician and I said, would you be offended if I suggested you follow the MD Anderson protocol for this guy? And he goes, no, I'd be more than happy to do that. So he only had to go to MD Anderson for 2 days to get the workup and the results and all that, come back. And then his own doctor treated him, and he lived another 12 years.
And I'm sorry, are you saying MB Anderson or MD?
D as in doctor.
Okay, thank you. In Houston, wow.
So, and MD Anderson is number one for certain kinds of cancers, but not for certain others. Johns Hopkins, so it depends on what you have, where you go.
Yep.
But that's the biggest disadvantage of Medicare Advantage, is a restriction of where you can go.
I'll just share this one more story, and then we'll go to our second break. And the company we know as Travelers today doesn't even write health insurance anymore, so nobody's going to be harmed by my telling this story.
Okay.
But given the job I had, one of the first responsibilities I had when I went to work there in 1987 was to write a letter for the guy who was the chairman and CEO at that time. I will never, ever forget these people's names. I had to write a letter to a Mrs. Mildred Cruz explaining to her that the Travelers was not going to cover the cancer treatment for her husband, Oscar. And I knew the guy who was going to sign that and send it off. And I wondered, how in the world, how does this guy sleep? I don't get that. Anyway, we're going to take our second break right now. We're going to come back during the break. I'm going to get out my compactor because there's a bunch of stuff I want to get into the last segment. So
Okay.
Please stay with us. We'll be back in 3 minutes.
Are you ready for the quantum age?
Humanity's next step in evolution?
Dream Vision 7 Radio Network invites you to the extraordinary platform of evolutionary voices for the quantum age.
Let's explore. Learn more about this upcoming age where we bridge science with spirituality.
Where potentiality meets reality.
Where we take compassion into action.
Our trailblazers and visionaries will ask the whys, the what ifs, while igniting continuous possibility.
Come along with us into an age beyond what we know today, where we can grow together in unity consciousness.
Experience evolutionary voices for the quantum age, Monday through Friday at 8 a.m. and 8 p.m. Eastern on DreamVision7Radio.com.
You can't establish your brand's authority without a voice. That's why, since 2004, O'Brien Communications Group, OCG, has been helping companies establish their authority, find their brands, distinct voices, and position their brands effectively and persuasively. So effectively that 9 of OCG's clients have been acquired by other companies. OCG's business model emphasizes efficiency and results, not hourly billing, markups, and media commissions. That ensures OCG's advice is unbiased and its clients aren't at financial risk. If you're ready to find your voice and use it to tell your story, OCG is ready to help. You can find O'Brien Communications Group on the web at o'briencg.com. That's OBRIENCG.com or call 860-944-9022.
Calling all authors. Have you been considering an audiobook? Well, look no further. Come take advantage of Dream Vision 7 Radio Network's unique in-house audiobook production, which includes benefits and bonuses from our radio station. Let our knowledgeable staff guide you to create the audiobook you've always dreamed of without breaking the bank. Check out our full one-stop service from A to Z, including the ACX process. Schedule a free consultation by calling 508-226-1723. That's 508-226-1723. Or go to DreamVision7Radio.com.
Everybody has a story. Everyone's story deserves to be told, and the only bad stories are the ones we don't share. That's why Mark O'Brien created The Anxious Voyage. It's Mark's conviction that every story deserves to be shared, and his purpose is to give people in all walks of life from any circumstances a chance to tell their stories. The Anxious Voyage is now on syndicated Dream Vision 7 Radio Network every Monday at 1 a.m. and 1 p.m. Eastern Time, with live broadcast every first and third Monday at 1 p.m. Eastern. Please tune in, please join Mark, and please share your stories.
This is Dream Vision 7 Radio Network, uniting mankind with universal love. Our shows are created from the heart, bringing each listener to a place of divine enlightenment. Breathe, relax, and enjoy. Let life flow.
Welcome back once again. I'm just going to jump right in here because I'm terrified we're going to run out of time. So I read here in your profile, Cathy, Parallel Profile is available to employers interested in improving the quality of care available to their employees and eliminating preventable and wasted costs for hospital care over $200 billion a year. So first question is, you can read anywhere people decrying the sad shape of the American healthcare system and how much money is being spent or wasted or whatever. So first question, how does Parallel Profile work? to try to reduce those costs and obviously keep people healthier in the process?
Well, what we do is we, of course, do PGX testing, okay? But it's making it actionable in the moment when it's relevant. So every time a drug is prescribed, the PBM knows, and we have an API with the PBM so that we know too. And if you're prescribed a drug that is in your red zone, one that can hurt you or one that no way can help you, and there's a bunch of alternatives, you get an alert on your phone, and it tells you, ask your doctor if one of these is okay. Okay, so it's very rare that there's not an alternative. It's very rare. And
okay, so if I were one of the people who were to get an alert on my phone, I would get it because my employer is working with you.
Mm-hmm.
Okay, so then it seems to me that part of the challenge is to get the word out to employers. And I'm certainly interested in knowing how to do that. And I also suspect that people who are watching us right now and or people who will listen to or watch recordings of this program would also like to know, what can we do? What should we and they do?
Well, I will tell you, because having worked with many Fortune 500 companies at my time at Towers Watson, that they have a 2 to 5 year strategy plan. They have it all laid out of what they're going to add and what they're going to change and what they're going to do and what gets renewed. They have a lot on their plate. It also makes sense sometimes to do things when certain contracts renew. So when your PBM is up for renewal, that's the time to say, you have to do this, or I'm switching to someone who will. Okay. It's not a minor technology thing. One of the things what we do is we say, this is what we recommend. Every night we're going to get a download from your PBM. We're going to look and make sure that everything is okay. If something isn't okay, we're going to alert the doctor who prescribed it and the patient, right? And then we're going to track to see if it gets changed. All right. We are also going to alert the company that they use to do their diabetes coaching, their mental health coaching, their cardiac care coaching. They have all these nurses and coaches that are reaching out to people, talking to them, and make sure that when we find out that this person is on a cardiac drug that can't help them or could hurt them, this person's on a diabetes drug that will not work, this person is on their third mental health drug that doesn't work, instead of adding Abilify, if this isn't working, add this, or if you have target dyskinesia because of a drug you're taking, add this drug. No, change the one that's making you do that. It's called polypharmacy cascade. Drug's not working the way it was intended because of your genetics. Switch to one that will. Don't add another one to treat the symptoms. What we find, there's a study that shows that 1 out of every 3 drugs a person is taking, they can stop taking when they fix the one that's causing the polypharmacy cascade.
Wow. I'm just thinking of all the commercials that I see on television that are doing exactly what you just described. And I want to throw in here, one of my favorite ones is, please don't take such and such a drug if you're allergic to it. Well, how in the world are you going to know if you're allergic to it if you don't take it?
Right. Well, and it's when the ad is running, they say side effects include, and then they throw a frisbee to a really cute dog who makes a really high jump, or 2 people are in a bathtub, or someone's got a cute baby, or whatever it is. But just watch the ads and you'll see the distress, squirrel. And they list side effects include sudden death, acute leukemia, certain cancers. And you're sitting there and you're going, but it's FDA approved, it must be okay. And all I'm saying is those things are all true. And 98% of the people can take my friend's macular degeneration eye drops, but he couldn't. 95% of the people can take, a certain cardiac pill, but 5% can't. We're talking in the last 10 years, 30 million Americans have been admitted inpatient. And, I'm not talking about ER visits. There's millions of those too. But 30 million have been inpatient in a hospital because of an adverse drug reaction. And those are the ones they recognize. They didn't recognize my husband's. They didn't recognize my friends. So in my example of the 4 people, 2 of them went unrecognized. That's pretty high lack of recognition. Okay. So it's the failure rate of diabetes drugs is like 38%. The failure rate of antidepressants is 50%. The failure rate, I mean, come on. So why try this one if it doesn't work? We'll try this one if it doesn't work. If we try this one, and believe me, because on my parallel profile, there's I have 82 that won't work as expected. Okay, and I'm average. One of our family members has 240.
Oh my God.
Yeah, so, and she's had 3 ADRs in her life.
Is that profile something that is accessible to most of us if we want it?
Yes, we like to go through employers, so it's part of the coaching and all that, because many doctors don't know how to read the results. So you take the test to the doctor, and I'll tell you, because before we started Parallel Profile, I got everybody in the family tested, and I did the reports myself. The first several took me about an hour and a half. After a while, I was able to figure it out in about 45 minutes. I took it to my doctor, and he knows my husband's doctor. He knows me really well, so he tried really hard. I took it to him about 3 days before my husband's appointment. And he comes in and he goes, Cathy, I really tried to figure this out. I really did. But I know you know the answer, so why don't you just tell me what it is, right? So we've gotten it down from 45 minutes to 3 seconds. So the doctor now has access to the app where he puts in the first 3 letters of any drug's name. And in 3 seconds, it tells them, maybe not this one because of these concerns, but all these are okay. Now, what we've also done with employers is we also have it so that we know what their copays are. So people will check the app, not because they are health literate or not because they understand genetics or not because they're wise to it. They'll check the app to see which one's got the lowest copay, because they constantly are calling their doctor when the PVM year starts over, and they call me, hey doctor, can I change from atorvastatin to Crestor because my copay went up on that one or whatever? And the doctor's office goes, yeah, that's fine. Go ahead. We'll fix it. We'll change it. And so they're going to look to see what the copay is for that drug. They're used to saying that.
I'm sorry, go ahead.
Yeah. So the point is interacting with the nurse case manager on your cancer case, interacting with the second opinion program. All right. Interacting with whoever's handling the back surgeries and things like that. A lot of people have a program now for that. Okay. They've got all these vendors interacting, and unless they're all on board and they all know what's going on. And so what happens is now we'll integrate with each of their systems so they don't have to go separate. They don't have to live somewhere else. It pops up if they have a parallel profile, they can click on it. They can do the 3-second search, right? And they can also tell a patient who doesn't have it, you should have it. If you're on 4 or more drugs, you should have it. If you have cancer, you should have it. If you are mental health and your drugs aren't working, you should have it, even if you're only on 1. But, and when you add the 5th drug, the odds of an adverse reaction go up significantly, right? You may be on a drug that is mildly disadvantaged by your genetics, but when you add another drug that uses that same protein, now this one that has never been a problem could become one.
So when you refer, presuming this is all employer driven, when you refer to the app, is that the Parallel Profile app?
Yeah. Yeah.
So just for the sake of argument, I'm my own employer, so I don't have a large company to go to. Can my primary care physician get your app?
Yes. Any physician who prescribes can do it. Any doctor can order a Parallel Profile.
Okay. All right.
But they just have to know that it exists.
True. Okay. So that's another word that has to get out. And the other question I want to ask you is, given what I heard in what you were saying before, is that networking is absolutely paramount in helping insurance companies to be educated about what they should be doing for the employers who buy their insurance. Would brokers be helpful in that?
Yes. Yeah. And as a matter of fact, I'm going to be leaving Wednesday morning for a 3-day conference in Washington, D.C. It's called Health Rosetta, and it's for the most innovative. You know Health Rosetta? Do you know who that is?
No.
Okay. It's a group of brokers and consultants who are extremely innovative. Okay. And they've championed transparent PBMs instead of the standard ones. They promote things that should be done that most people don't have time to do or don't know about or whatever. So I'm going to be there for 3 days and have a lot of meetings set up. So that's the way. We do. Our hope is that employers will do this, and then they'll have the results that they can go speak to at conferences themselves. That's how I've done it in the past, and it's been very effective.
Okay. I am going to I'll reach out to you after the program because my number one son works for a major brokerage firm, and I don't want to name names, but I want to find out if they're going to be represented in Washington when you're there. So I'll figure that out. So people can find Parallel Profile at parallelprofile.com.
Yes.
And before we go, is there anything else you would like folks to know about that?
No, I want people to be aware that there's risk out there, and you should not be afraid, but also not be foolish. And, a lot of the recommendations that PGX says is, this seems to be a problem for some people with your genetics, but not all. So be on the lookout for it. So if you do get TK, instead of adding another drug, you will know, I should switch this one, right? If if you have a reaction that's on the box, you can look at your Parallel Profile and switch to one that won't give you that reaction.
Okay. And along with risk, I do want people to know that thanks to you and your work, there is also help and hope. So thank you for that. Thank you for being here, Cathy. I'm so grateful. I would like to reserve the right to invite you again, because I would love to believe that we'll continue to make progress, and I would love to get some updates.
You bet. Happy to.
Okay. Thank you very much. Thank you for everyone who tuned in today. I will be back 2 weeks from today at 1 p.m. for another program, and I'll see you then.
Thank you for tuning into The Anxious Voyage, the program dedicated to sharing stories, helping people, and celebrating life. You can see and listen to The Anxious Voyage on syndicated Dream Vision 7 radio network every Monday at 1 a.m. and 1 p.m. Eastern Time, with live broadcast every first and third Monday at 1 p.m. Eastern. If you have a story to tell, or if you know someone who does, please email the host, Mark O'Brien, at mark@o'briencg.com. In the meantime, please remember, the only bad stories are the ones we don't share.
This is Dream Vision 7 Radio Network, uniting mankind with universal love. Our shows are created from the heart, bringing each listener to a place of divine enlightenment. Breathe, relax, and enjoy. Let life flow.
Cathy just